Good morning, everybody. Welcome to Phoenix Children's Grand Rounds, virtual Grand Rounds. It's my great pleasure this morning to introduce our speaker, Dr. David Adelson. Dr. Adelson is well known to many of you, so I'm going to try to sprinkle in a couple things here in the introduction that you may not know. Dr. Adelson is the director of the Barrow Neurological Institute at Phoenix Children's Hospital. He is the Diane and Bruce Howey Endowed Chair for Children's Neurosciences and the Chief of the Department of Neurosurgery at Phoenix Children's Hospital. Dr. Adelson is originally from Long Island, New York. He completed both undergrad and medical school at Columbia University in New York City. In undergrad, he double majored in biology and philosophy. He then moved west to California to do a residency in neurosurgery at UCLA, and then back to the East Coast for a fellowship in pediatric neurosurgery at Children's Hospital of Boston and Harvard Medical School. Dr. Adelson came to Phoenix Children's in 2009 from the Children's Hospital of Pittsburgh. He's been very active in a number of national organizations, including serving as the chair of the editorial board of the Journal of Neurosurgery. He currently serves on the board of directors for the American Association of Neurological Surgeons, and he was past president of the Congress of Neurological Surgeons. He has over 250 peer-reviewed publications. He's given countless keynote addresses and invited professorships and other invited presentations all around the world. Dr. Adelson, it's a pleasure to have you speak at Grand Rounds this morning. It's all yours.
Thank you. Just going to share a screen and we'll get going. So thank you all for being here this morning, and appreciate the invitation to tell you a bit about what's going on in the world of epilepsy, and in particular the surgical management. So just one disclosure, I do work as a consultant for Medtronic, and while there are a number of products that we use with Medtronic, I will refer to most of them in the generic. Surgical treatment of epilepsy has really been around a long time. Actually, the first treatment was in the 19th century, where a patient with epilepsy was treated with brain resection. But the reality is that knowledge comes along and trickles along at different paces. And for the most part, when we talk about sort of the early part of epilepsy and its management, the surgical treatment has really been very slow in its acceptance. Mostly had been done in adults. Mostly those patients had good to excellent outcomes, really because they had a very focal area of abnormality, which was the medial temporal lobe. Unfortunately, epilepsy still is the most common neurological disorder of childhood, with an incidence of about 2%. And the reality is, and what I hope to impart to you today, is that surgery has and should be considered when alternative treatments, whether it be medication, diet, or otherwise, fails. So I'm just going to give a quick case presentation, and that I'll come back to later, but just to give you a flavor of some of what we might do. So this is a 3-month-old young girl who was diagnosed at birth with tuberous sclerosis. She started having seizures at 6 weeks of age, but likely they started at least at birth, if not actually even in utero. She really had what we would consider catastrophic epilepsy, so 50 to 60 seizures per day. The medications would reduce her number to about 3 to 5 per day initially, but then medications quickly failed, and unfortunately multiple medications failed in rapid succession. This was a child who was not meeting any developmental milestones, poor neurologic exam, and was really not in good shape. Her evaluation, EEG localized to left frontal region, and you can see here on this MRI these abnormalities. She had multiple tubers throughout her brain. You can see one here. Here's one down here. But you can appreciate the fact that there's abnormality that correlates well with the left frontal region. So then, what then are going to be the next steps? And so that's really what I hope to impart to you upon today. This is sort of a common presentation of someone with lesional epilepsy and what we would do in this situation. So just to give you a flavor, going back to the incidence, this is just, again, an age distribution of the different times at which epilepsy can, the onset of epilepsy can occur. And you can see in early age, it starts out fairly high, then decreases through middle age, and then increases again as into the geriatric population. Interestingly, with regards to refractory epilepsy, most patients, about 50%, will become seizure-free with the first drug. The reality is that as you add more medications, the likelihood of becoming seizure-free becomes less and less. So we know we can add another 11% will become seizure-free with a second drug. After a third drug, maybe another 4%. But the reality is, after 2 or 3 medications, there's about a third of patients that will become refractory to medication and/or any other treatments. So when one thinks about the treatment gap, particularly for these patients, if we think about an epilepsy prevalence in the U.S. of about 3 million people, there's about 1 million patients in the United States, 1 million people with refractory epilepsy. And if we think about sort of the incidence, as I mentioned earlier, and there's about 150,000 new cases each year, there's only about 50,000 new cases of, as a result, there's about 50,000 new cases of intractable epilepsy. But the surgical treatment of it, where we can actually cure patients in many instances, is very, very limited and very low. So as a result, there's a growing population of patients that really don't get treatment or adequate treatment in order to manage this really devastating disorder. There's a multitude of differences between adults and children with regards to the types of epilepsies we see. Frequently, as I mentioned, adults, they have complex partial seizures of temporal lobe origin. As a result, this is a single small focus. And the reality is we define intractable as not responsive to medication, but intractable of greater than 1 seizure per month may or may not be the best definition. Obviously, having epilepsy as an adult can impact one vocationally, psychosocially, the ability to drive, those kinds of things really do have a significant impact in adults. In children, when they have their seizures, most times we see a diffuse, more generalized seizure type. As pointed out in the case presentation, they're often extratemporal, cortical. Oftentimes we do find lesions, but they're often not a small focus. And as I mentioned, there can often be numerous seizures per day. As a result, between the impact of constant seizures and the medications to try to control those seizures, many of these patients go on to have cognitive and behavioral developmental issues that really are significantly impact them as they get older. So the goals of any epilepsy intervention is to stop the seizures. We're doing this in order to prevent the further brain injury or interference of the seizures on normal brain function, and in children, the ability for normal brain development. So if we have that impact of constant seizures and the need to drug them up such that we try to control the seizures, then we're really not allowing for normal neural development. So then what are the goals of surgical intervention? They're the exact same thing. But what I would argue is that if indeed we can come up with complete cessation of the seizures, we can cure their seizures, then our goal is to hopefully allow for more normal neural development, or at least allow them to maximize their neural development in the long term. So we define epilepsy surgery as really the best option for qualified candidates to achieve a cure. And the reality is that for resective surgery, the best patients, the ones that have the best outcomes, are those that have focal onset seizures that we can identify, seizure focus in a region of cortex that's safe to remove, and then lastly, that they're drug resistant. So we're not jumping in to operate on everybody, but we would like to see patients that have those that have already failed 2 or 3 medications, since the likelihood of them improving is very, very low, that really surgery provides the optimal opportunity in order for them to be best managed. And again, while I say drug-resistant medically refractory and we use anti-epileptic drugs as our mainstream, there are many patients that do respond to things like the ketogenic diet and to cannabis, so epidiol. So obviously those alternative treatments would also be considered under refractory treatment. So with regards to the decision making, we're really dependent on the seizure type. We like to identify where the seizures are coming from, both their lateralization as well as their localization. We have a number of ways of doing this identification through both non-invasive and invasive evaluation, and I'll touch on those. But the most important is really the concordance, or bringing all of the data that we have in these patients in order to define what is focality. And then clearly, if we can identify a pathologic substrate, a lesional case like I presented earlier, those are going to be the best outcomes. Those with non-lesional, we then have to spend a bit more time trying to identify where indeed those seizures are coming from. And while I may say that they're non-lesional, the reality is at a microscopic level, frequently these patients have a cortical dysplasia or abnormality that we're just not seeing on our present diagnostic imaging capability at this time. So where have we come, and really since the 19th century to now, clearly the improvements that we've been able to do, which is with regards to identifying where the seizures are coming from. We clearly have improved anatomic imaging. We've improved functional imaging, and functional imaging is the most important because indeed epilepsy is a functional disorder of the brain. So whether there's a lesion there or not, it's really the function of the brain that we're most concerned about. And then the ability to map or being able to co-register all of these different modalities into one, which then creates a much more robust surgical map for me and my colleagues in order to identify and then hopefully treat these patients adequately. So with regards to what we consider our non-invasive evaluation, this is our comprehensive evaluation for any patient who has intractable epilepsy. And so again, the definition of intractable is non-responsive to medical or other treatment, and ideally, one defines, as I'll mention a bit later, intractable has different definitions for different people. So for some people, if it's one seizure every 6 months and they can't drive, that's intractable. For others, when we're dealing with a catastrophic case, as I presented, they can have 50 to 60 seizures a day. That's a whole nother level of intractability. But having said that, the standard evaluation is one in which we obtain history and semiology, because there's often clues into where the seizures may be coming from by the abnormal functions that we hear with regards to the seizures. The EEG, which is a functional test looking at the electrical activity of the brain. Video EEG, which is so marrying up the semiology and the EEG to try to identify where the seizures start clinically and then how they spread. Neuroimaging, both anatomic and functional. Neuropsychological assessment in order to assess what the impact seizures and their medications are having on neural development. And then there's other functional tests that I'll touch on in a little bit. With regards to our anatomic imaging, really the mainstay at this point is MRI, and now with advanced sequences we can really tease out the lesional and non-lesional areas. Functional imaging, as I sort of mentioned, but there's also what we can sort of term electrophysiologic imaging with something like MEG where it's really a multimodality combination of data in order for us to have a concordance and an understanding of where the seizures may be arising from. So now to touch on neural imaging, here typical MRI doesn't look particularly abnormal, different sequence. For example, here with a different sequence you can appreciate here a dysplasia in the left insula, and then again with different views you can really pick out and now start to create a 3D map of where this lesion arises from and where there might be potential opportunity for treatment. Diffusion tensor imaging allows us now to map tracks and be able to see where, for example, where we would be wanting to avoid, let's say, motor tracks or visual pathways or those kinds of things. So having this anatomic map allows us to sort of see where is eloquent tissue as well as where we would be worried about creating deficits if we were to do surgery. But again, as we advance from maximally invasive type of procedures to more minimally invasive, we often use these maps in order to create pathways that would be safe and opportune for us to try to gain a treatment opportunity for these patients. With regards to functional imaging, again, there's a whole series of functional imaging options. Many of them we use here and we have on site. Hopefully soon we'll have MEG with our partners at St. Joseph's. But clearly there are many opportunities for us to sort of tease out abnormal function in the brain through a combination of these different modalities. Here's a PET image. This is an old image showing, again, here left temporal hypometabolism, so areas of the brain that are dysfunctional, not functioning like the rest of the brain that you see here. Here's being able to marry PET onto an MRI. Here you can see the normal metabolism, the color scheme, and then an area of hypometabolism back here in the parietal area. This then allows us to now truly create a map for us with regards to the brain, where there's abnormal function, as well as where are some of the anatomical landmarks that we might use. SPECT has also been used mostly in the past. We don't use SPECT here as frequently, mostly because of the need to get these injections in early. Here's an interictal SPECT that does show a little bit of a low flow, cerebral blood flow region in this area here. More importantly is the ictal SPECT, and you can see very hot area where there's increased activity from, let's say, a seizure, and we're able to now map cerebral blood flow in this region. Now we have an area that says to us, well, this is where the seizures are onset. But again, these injections have to be early on when seizures are detected. And then we can do what's called a subtraction, and one can appreciate if we take the ictal and subtract the interictal data, you can have a nice map here for where there's the seizure onset. And then again, using multimodal type of mapping, we can then map that directly onto an anatomic image and give us a map to be able to consider a surgical intervention. Functional MRI, classically, has been based on what's called task-based functional MRI. That requires a cooperative patient. They have to be awake. They have to be able to lay still. And then what we try to do is to do testing of these different modalities through some unique tests that have been while they're in the MRI and while we're scanning. So we're looking at blood flow changes in those different areas of the brain. The reality is that it's difficult to impossible to do in a child. And so task-based functional MRI has really not gained any ground in young children. Now, in a mature teenager, yes, we can likely do a task-based functional MRI. but that's not really the majority of our patient population. For that reason, really with the development of resting state functional MRI, which really PCH has been championing in this area, really a leader throughout the U.S. With Verena Burwinkle's work here and originally at Texas Children. What we're looking for is to look at changes in cerebral blood flow in the brain, in the ability to look at where are functional networks. And so we're really looking at the brain at rest, and we're looking at blood flow changes that indicate normal areas of function, and then comparing those or mapping those really to areas where there's abnormal blood flow indicating abnormal functional network. Here are just some typical, networks we would see for resting state functional blood flow or bold signal. Then here would be language networks, and here would be patient, here's left language versus right language. And again, these are areas where we would expect there to be normal functional networks. When we start to then look at areas where there's abnormal functional networks, here's one where we see an abnormal functional network within the left temporal lobe. Again, this is comparative to the contralateral side. We can see that there's the potential for the seizure focus being in this area and being the source for this particular patient. Here's a seizure focus near a temporal lobe tumor. You can appreciate the tumor here, and again, we're trying to map. This is a patient with a low-grade tumor who we're now trying to figure out, are we able to encompass curing the tumor as well as curing their epilepsy? And one can appreciate in these slides and in these figures here that indeed the seizure focus was tightly aligned with the tumor, but it's on the, again, the posterior lateral aspect of it. We wouldn't know without this type of modality, is the seizure focus more frontal, more medial, etc. So this allows us to do a much closer localization of an abnormal functional network in the area of the tumor. MEG has also been used, and I mentioned it a bit earlier. And again, what that tries to do is create concordance between what's called magnetic source imaging, so looking at abnormal dipoles within the brain that the MEG can pick up, and then mapping that onto an anatomic image to provide us, again, where's the vast majority of abnormality within the brain, and being able to see that both functionally and anatomically at the same time. This is a great example where MEG was quite useful. Here was a patient who on EEG and his workup had frontal lobe seizures, but yet had this lesion back in the parietal area. Here was his MEG, which really had a big focus right in the area of where the lesion was. This was really early in our experience, but this was helpful in trying to bring into question, were we indeed having concordance of the data, which was not clear. And so for that reason, we were really quite focused on, do we take into account the standard by which we've been making decisions, or now with this new technology, is this something that we should focus on? And I'll come back to this in just a little bit. With regards to other diagnostic, when we don't have concordance of data or insufficient data to lateralize or localize the seizures, then in those instances we move toward an invasive monitoring strategy. There are a number of different methods, and I won't belabor those, but many of you have seen some of these patients with electrodes in place, more because we focus on chronic invasive methods versus the acute. Intraoperative mapping awake craniotomies in children is not my idea of fun, and it's not really an easy process even in the adults. And so what we tend to do is place the electrodes, secure them, wake up the patients, and then map the seizures in real time in a controlled setting in the epilepsy monitoring unit. Here's just a typical look of stereo EEG with an abnormality in the left temporal lobe, and you can see the series of electrodes in this particular patient. Here again, I'll show another MEG image. Here's some MEG that indicated here left parietal abnormality. Here's the depth electrode stereo EEG strategy that was used in order to target that left side. Based on our EEG, we weren't clear whether it was bilateral, so we placed a couple of electrodes on the right side. Here is the eventual resection, because indeed the area of abnormality mapped right to where the MEG pointed us and where the stereo EEG really confirmed this as their seizure source. This was a patient from Colorado, and this patient has been seizure-free since resection. Here is a patient with a more extensive lesion here in the insula. You can appreciate that here on the anatomic imaging. For a strategy of a deep lesion like this, we want to place depth electrodes, and so we would place a series of electrodes around that lesion, but then we also have to consider that there may be a surface abnormality. And so here's those 4 electrodes mapped around that insula, and then what we do is we placed surface electrodes on top of that in order to be able to get a larger map or larger understanding of what's going on. So surface electrodes, again using grids, are really quite helpful for us, because not only can we map out where the seizures might be arising, but similarly, we can also identify where there might be important cortical areas. In this case, we were able to map out Wernicke's area here and obviously Broca's area here. And so being able to consider, how close would we be safely to do a resection in this patient. So not only can we record from the electrodes, but we can also stimulate back and basically create a cortical map of function. So what are our options once we've defined where the seizure focus is arising? There's a number of different options, and I won't go through every single one of them. I wouldn't have time for that, but suffice it to say is that we have a lot of options for patients in this day and age in order to try to manage their treatment. Obviously, some of them are still on the horizon. We don't do transplantation at this time, and there are some places that are doing TMS for trying to treat neuromodulation of seizure foci. But again, for the most part, we're able to do the rest of these different options today. Resective surgery, temporal lobectomy is really the most common one, and that's because the seizure focus is most routinely in a very confined and very focal area. It's very easy to see on, as I mentioned or shown in the, whether it be the resting state or the PET scans, and in those instances, we know that we can do well by the patient with really wonderful outcomes. Invasive monitoring used to be the mainstay for us to define seizure foci, but now with the imaging, we no longer really have to depend on that. We will often use invasive monitoring if we're not sure if it's coming from both sides, and in those instances, we would place electrodes in order to see whether the patient potentially would be hurt by having one temporal lobe removed. Here's just a pre and post-op view. Here was a significant abnormality of a cortical dysplasia, and then following resection of the temporal lobe in this case. Extratemporal resections, much more common in children. These are patients that end up most commonly with invasive monitoring, so the phase 2 or diagnostic invasive monitoring. Our imaging technologies have clearly added and have been really able to now more clearly define areas where we need to map and see where the foci are coming from, as well as where there's eloquent areas of brain that we don't want to try to injure or try to avoid. So clearly concordance of the data really is dependent in these instances. Here's a patient with a significant schizencephaly, so clear abnormality within the brain. You can appreciate that. Here was the SysCom image, so using that subtraction imaging with SPECT. Here's exposure of that abnormality, and then our surface electrode strategy, what would this strategy would be in this place for this particular patient. Here's just the skull X-ray, and then this is the EEG, and one can appreciate areas of where the seizures were coming from and how those really map into these different areas here. And so then this patient becomes has an opportunity for surgical treatment and resection. Cerebral hemispherectomy. In the old days, we used to call this the ultimate focal resection, where you remove the whole hemisphere. And again, the purpose is no different than any of the other surgeries that we do, which is really to stop the intractable seizures and allow the functional, the more normal hemisphere to be able to take on the other functions of the brain. The technique has evolved over time, so when I started it was a complete removal, and then I've been through the evolution so that now, for the most part, we do just a disconnection of that hemisphere in order to gain the same effect. And in fact, we have a case of cerebral hemispherotomy today after my lecture. This is the technique we now use, very small incision. We're able to access into these areas and basically disconnect the brain through this small window that we create in the brain. This is a case in which, and these authors used a percular approach. I tend to use a temporal opercular approach in order to achieve this disconnection. Again, there are multiple disconnective procedures, and while cerebral hemispherotomy tends to be curative, corpus callosotomy and subpial transections, unfortunately, usually are really focused on really trying to disconnect the seizure network from spreading. So unfortunately, it doesn't remove the seizure focus, it just disconnects it, hopefully, from the normal functioning brain and allows for more normal function of those different areas. Callosotomy has been around for a long time, really since the mid-20th century. But unfortunately, as I mentioned, it rarely produces a seizure-free state. Here's just a view of how, through a very small incision, we can visualize the interhemispheric approach to the corpus callosum. Here's anterior, and we're looking, here would be the nose up here, the back of the head back here, and this is the midline within the corpus callosum. And then here's the fibers disconnected, and you can see the ependema of the ventricles there in this particular patient. With regards to hemispherotomy, this is just a view, a CT scan showing just the disconnection of the hemisphere coming into the ventricle, the callosotomy, and then the disconnection of the frontal orbital area as well as the parieto occipital area. The results are fairly good. This is an old series that I published a number of years ago, but one can appreciate with temporal lobectomy really excellent outcomes with the right choice of patients, but even good outcomes, really across other areas of treatment, including in the hemispherectomy patient population. With regards to hemispherectomy, really good seizure outcomes. Again, you're taking a hemisphere that's interfering with the normal neural development, and particularly in patients in which, if this is done at a very early age, these children will, be walking, running, playing, go to regular school, those kinds of things, as long as the contralateral hemisphere is otherwise anatomically and functionally preserved. And so we really do give an opportunity for improved quality of life in these patients, particularly with the catastrophic epilepsies. And then callosotomy really focused on atonic seizures, so we can cure the atonic seizures in upwards of 50%, but it only very rarely gives a seizure-free state across all the different types of seizure foci that potentially could be treated with this intervention. Just some of the complications. Again, there's no surgery that doesn't have the potential for complications, but if we look at complications as a whole, they're much less than having ongoing seizures. So, for example, I've not had a patient pass away from epilepsy surgery, but yet SUDEP, which is sudden unexplained death of epilepsy, as you've probably heard in previous talks, is a significant problem, and it is the reason that surgery is safer than going on and having continued medically intractable seizures. Hydrocephalus with anatomical hemispherectomies was about 30%. We've almost eliminated that. It's down to below 10% in patients with the hemispherotomy. So overall, with regards to resective surgeries, we've had really good results, and complications remain low. So just follow up. This was that child I presented earlier, the 3-month-old. She had the surgery for the frontal lobe, and we resected that abnormal area. It was guided by doing intraoperative electrocorticography. She was in the ICU for a day, regular room for a day, and then went home. This is her incision. You can see it up here. This is her seen on postoperative day 2. Thank you, Dr. Wilfong, for this picture. But this patient did not have seizures following surgery. First time had a smile, and first time had eye contact. So, again, immediate response because of the catastrophic epilepsy that this patient had. Well, not all patients are able to undergo this type of surgery, and so more minimally invasive approaches have been developed. One of the ones that we've championed here is stereotactic laser ablation. Really, because it is minimally invasive, our goal is to try to avoid injuring eloquent areas of the brain and to try to target our seizure foci in a much more finer way and in a much more confined way. The reality is that not only do we have to consider when we do resective surgery what we're resecting, but the pathway by which we get there. And sometimes there's going to be injury to the brain through those pathways. And so not only do we have to consider the seizure focus and maybe the surrounding eloquent tissue, but also the strategies for getting to that seizure focus. And so stereotactic laser ablation really does provide an opportunity for those patients where, let's say, we have a deep target and provides it in a minimally invasive way to ablate or resect, for lack of a better word, that area. As I mentioned, it's less invasive. We're able to discharge patients the next day, but it's really best when there's a well-circumscribed, relatively small area of seizure focus. And so we can have a danger of being too precise, particularly when we see cortical dysplasias. We have to recognize, again, as I mentioned earlier, epilepsy is a functional or a network disorder, and so we've got to marry a lot of that data together in order to decide whether indeed this is the best strategy for management of these patients. Well, here's just a typical laser probe in place. It's a small incision, about 2 millimeters, placement of the bolt, and then the laser probe to the target that's done stereotactically. We've been originally, we started off doing this for patients with hypothalamic hamartomas, and then now expanded to a number of other pathologies, which I'll point out in just a sec. But having said that, we can place this laser probe while the patient now is in the MRI scanner. After placement, we can see the probe in the target, and then using MR thermography be able to map out where we're creating cell death with the temperature elevation. So here's an MRI of a 2.5-year-old with gelastic seizures. You can appreciate on this slide the abnormality on the MRI, very small. How would we get to this target without going through normal parts of the brain or interfering with other parts? We know that there's some important structures right nearby, so we're looking at ways to try to target this in the least invasive way. Here's a laser probe in an area similar to this. You can see the temperature maps that are created by placement of the laser probe. And then this would be what we would see after the ablation. So here's diffusion-weighted imaging showing cytotoxic edema in the area that we just ablated in that particular patient. And you can see here on the T1 with contrast, again, here's the laser probe in that lesion and where we created the ablation for that particular abnormality. Here is another patient that came to us from Hawaii with gelastic seizures. She was 14 years old and had seizures since 6 months. And so first they had to have recognized that she was having seizures, but she was having upwards of 6 seizures per day, tried on multiple medications, but really with no impact, and then really was sent to us for evaluation. Interestingly, her EEG was non-localizing, which is why originally they weren't sure whether she was indeed having seizures and even whether she had an abnormality in the brain. Really here you can see this in this particular patient where the hypothalamic hamartoma situated, but as well just the imaging, especially given our imaging here, we were able to map out where her mammillary bodies were relative to that hypothalamic hamartoma. So very important structures that really are stuck on both sides of the hypothalamic hamartoma. And this was really towards the front of the lesion. So here you can see the lesion on the MRI here, as well as the mammillary bodies and the fornices here. And then what really marrying in our technology with resting state functional MRI, we were able to see this lesion and then map the direction of the functional network. And so we saw that the connections creating this child's seizure network really went posterior and down away from this area. So again, if we look where the mammillary bodies are and we look to see where we can potentially target safely, this is what we mean by the concordance of data and utilizing that for creating our pathway and our target. So here's the laser probe in that hypothalamic hamartoma. We were then able to ablate, and this just shows the cell death map after the thermography. And indeed, in this particular case, we achieved what we sought to do in a safe manner. That patient has been seizure-free since the ablation. We can also do laser ablation in other locations. So as I mentioned, for temporal lobe, where we used to do a large temporal lobe resection, if they've got a localized lesion in the mesiotemporal lobe, we can do an ablation of the amygdala and hippocampus. Here one can appreciate that on this slide here on the cell death map. Also cortical dysplasias. Here was a patient with a focal cortical dysplasia that we were able to map out and ablate in this region. This was done with multiple laser probes, and you can see that there. Here's the post-ablation imaging. So again, able to achieve what we accomplished. As I mentioned earlier, we can also do laser ablations for brain tumors. This was a patient with a recurrent medulloblastoma. So instead of going back and re-resecting this recurrent tumor, as this patient was likely going to, went on to need chemotherapy and radiation, here was a case where we could do a more minimally invasive approach and get this patient to more definitive treatment sooner. I'm now going to just touch on neuromodulation. There are a number of different methodologies, and I'm just going to touch quickly on VNS and RNS. Many of you have seen those patients here again in this hospital. We're just starting the DBS program here, and look forward to talking about that in the future. VNS, as I've mentioned to many, is not surgery. It's basically another medication. It's really for patients that unfortunately don't have other options, or other options have already failed. We consider it for patients with more diffuse type of seizures, particularly if we don't really or are not able to identify where the seizure focus is arising. Here's just an overview of its implantation. Electrodes placed around the vagus nerve within a pulse generator. The surgery itself takes me about 45 minutes. Total case is about an hour, hour and a half, and they usually go home about an hour to two after surgery. It's just 2 incisions, one in the neck and one on the chest, dissolvable stitches. The patients really do tolerate them quite well. This is just here you can see the incisions. The vagus nerve is looped here with the electrodes, and then just the implantation of the generator. Multiple models have evolved over the years, and we tend to use the most recent generation, which is now programmable for not just different times of the day, but also with regards to a little bit of what we call a closed loop system. So reads when the patient's heart rate goes up, indicating a possible seizure and giving them an extra stimulus. Good outcomes over the long term in these patients, much better than patients who continue to be tried on medical therapy. So again, if 50% of patients are getting a greater than 50% reduction, that's much better than a 4% chance or a 1% chance with a new medication making a difference. So again, as I've already sort of mentioned the results. With regards to RNS, we started this about 2 years ago. Again, refractory epilepsy, but mostly in patients where resection is not possible. So language areas, for example, or in certain if it's in both temporal lobes. So those would be instances where we really can't remove those parts of the brain or ablate those areas, and so we would consider an RNS strategy. It is FDA approved for adults only, so we've been able to do it off-label for patients, late teenagers, and that's really where our focus has been. It involves a neurostimulator as well as the wiring where the electrodes go. Here's just an example, the leads. There's a surface electrode as well as a depth electrode, and then the implantation of the generator is actually right in the skull. And then through using a wand, you can program the device to pick it up. The importance of this is that this reads a seizure, and then the generator stimulates back along the electrodes. So that's the reason that we place these electrodes as close as we can to the seizure focus to try to interrupt the seizures from spreading. Here's just a typical implantation of a strip electrode with a depth electrode, and here's the generator. Here's just a placement of a few surface electrodes, trying to optimize which electrodes, because here the generator can be read as to which electrodes the seizures are most commonly coming from, and you can see sort of just a typical implantation strategy. The outcomes in these patients have been very good, and that's the reason that we've moved in this particular area. Just to move on to just quickly, I'm just going to glance on this because I'm proud of this for PCH. Really, led this area with regards to neurosurgical robotics. There were a couple of first-generation robots that were out there. We most recently, just last January, started using the Stealth AutoGuide, which was really a new generation with a much smaller application, much more usable. Here's just, you can see the robot here within our operating room, really married to our image guidance systems, as well as so our ability to do not just depth electrode placement, but biopsies and laser ablation has really been how we've used this device. This is just the device in place. Here's the patient. Here, the robot is able to line up the approach in these patients. The robot is not doing the surgery, for those wondering. This is just really providing alignment for us for our different invasive methods, particularly when we're trying to thread a needle in a very fine location. So typically, so here you can see how close our targets can be to 0.7 or 0.1 millimeter location. So when it comes to the ability to target these areas, we're able to do it in a very exact and accurate way. So just here's just using that to localize this. Just going to play this short video.
The tolerance of this is millimeters. If we went just a millimeter too close, she would have a paralysis. We're really grateful to have these type of advanced technologies here at Barrow Neurological Institute at Phoenix Children's Hospital. It's very important to have this type of accuracy, and the reason being is that in this particular case, we needed to do an ablation deep as well as more superficial, and in between, though, was this child's basal ganglia, which is a major motor processing center. This was the first use in the United States for the Stealth AutoGuide, and this neurosurgical robot worked very well for us.
So in summary, intractable epilepsy, particularly in children, we know impacts mortality, morbidity, and quality of life. And we know that outcomes from surgery are much better as compared to continued failed medical therapy, particularly in selected patients. So yes, it's not for everybody, but in those patients, we really do have great outcomes for these patients. We know that surgery and interruption of seizures that interfere with normal function and normal development really truly makes a difference the earlier we can do it. So when we look at young children, we really do need to consider being aggressive in those patients in order to provide the opportunities for cure, and we know that good outcomes lead to whole new lives. I like to tell this story. This is a young woman I took care of back in Pittsburgh. She came to us as a 15-year-old who had a temporal lobe epilepsy with a mesiotemporal sclerosis. Her parents were scared of her undergoing epilepsy surgery, and so said no to the option. And 3 years later, Rachel came to us. She was now 18. She said she wanted the surgery. She's been seizure-free since. You can see she ran a marathon 4 months after, and she went on to become a river guide on the Colorado River. So just it does indeed make whole new lives. She wouldn't have been able to do that with her epilepsy. So with that, I really do need to highlight that that this could not be done without a team. We have an amazing comprehensive epilepsy center here with really fantastic group of people who really make the treatment of epilepsy here in Arizona and beyond, because as I mentioned, we've had patients from all over the country as well as the world come here to be treated by this group of wonderful individuals. So with that, I thank you and appreciate your time today.
Thank you, Dr. Adelson. That was fascinating. We do have a couple minutes here for Q&A. You're welcome to either unmute yourself and just ask Dr. Adelson directly, or you can submit a question for chat. Well, we'll do one last call for questions. If not, Dr. Adelson, thank you again. It was excellent, and everybody have a great day.
Thank you. Thank you all, and have a great day.